Hi, my name is Laura Carson, and this is my arterial line assignment for hemodynamics. This is option A, the video assignment. So I'm just going to start by talking about the questions in the assignment. So first off, how much experience do you have with this technology in a clinical setting? So for arterial lines, the ICU nurses are generally the ones who do the priming and actual technical setup of the art line. But we are involved with this obviously because we're the ones inserting the arterial lines here as respiratory therapists. So we do have a lot of experience zeroing, calibrating, looking at arterial waveforms, as well as if the nurses are really busy, we do prime our own lines from time to time. So for the second question, where are you using this technology and where would you primarily recommend it? At my facility, arterial lines are used in two main places, which is the ICU. I deal with them a lot because I put them in there, as well as in the operating rooms. However, as a respiratory therapist, usually we're not involved in the ones in the operating room because the anesthesiologists or the anesthesia assistants are the one placing them and managing them. Sometimes if it's rare, but we can see them in the emergency department because usually they're either headed to ICU or the operating room, which they would just get the line there. So list and describe the physical principles used by this technology. So how arterial lines work, it's composed of a fluid-filled intravascular catheter, pressure tubing, a pressure transducer, and an amplifier. So what happens is the pressure that the patient is putting out travels through the low compliance tubing of the catheter. This bends the diaphragm and the transducer, and then this gets converted into electrical signal, and then it's amplified by the amplifier onto the monitor, which gives us our pressure. So the advantages of an arterial line is that the main advantage is that it gives a real-time blood pressure reading. So this allows the clinician, whether it be nurses, doctors, anesthesiologists, RTs, to adjust their treatment based on real-time blood pressure. Another big advantage of arterial lines is that it allows for frequent blood draws, so especially frequent arterial blood gases. This is also an advantage because it avoids the poke for the patient, as well as it avoids the RN or the RT having to poke them. So the disadvantages of an arterial line is that it requires proper positioning and zeroing to be able to have reliable values. If it's not zeroed, if it's not leveled at the phlebostatic axis, then your blood pressure measurement is not going to be accurate in your waveform. You're not going to be able to interpret anything from your waveform. The other disadvantage is that it requires, not anybody can do an arterial line. It requires a skilled clinician. So either an anesthesiologist, an anesthesia assistant, or a respiratory therapist generally are the ones placing them. The big disadvantage is that it is a very invasive procedure. You are introducing a foreign catheter into an artery, and it's going to stay there. So with this, there's a risk of infection. Because it's an artery, there's a risk of hemorrhage, hematoma, thrombosis, as well as ischemia of the hand. So I think that about does it for the questions. In the next part of the video, I will be showing how to prime an arterial line, as well as zero and level it. So for this portion of the video, I'll be demonstrating priming the arterial line. So just as equipment, we have our 500 ml bag of normal saline, our pressure bag, our transducer cable, the dead ends for after the line is primed. And then in addition to this, we would also, if it was a real patient setup, have an IV pole and a transducer holder. So we're just going to start by pumping up pressure bag, and it's going to be pumped up to 300 millimeters of mercury, which prevents backflow into the patient's system because it is far over the systolic pressure. So there's 300 there now. And so next what we're going to do is we're going to spike our bag. So next up for this, we have our roller clamp that comes down to the first line that we're going to prime. So we switch the stopcock off. You may have to squeeze it a couple of times to get the water to fill. And then we're going to flush it to get all the air bubbles out. And once all the air bubbles are out of that portion, we're going to switch it back off and continue down the line. And do the same thing with this one. So we're going to turn it off this way. And continue to flush it. So that there's no air bubbles. Then once again, we will switch it off to there. And finally flush it to the part that's going to connect to the patient. So at the end of this, there should be no air bubbles. All the ones that we just flushed have holes in them, so they need to be replaced by the dead ends. And then this can be ready for patient connection. So now that the line is all primed, we are ready to turn it to the patient. So the transducer is placed on the patient at the phlebostatic axis, which is the level of the right atrium. So usually the patient's lying in the supine position. And this is about at the fourth intercostal space, kind of in the mid-auxiliary line where it's going to be leveled. And then this portion will connect to the transducer cable that connects to the monitor. To zero this, the stopcock at the end of the line must be off to the patient, so it allows it to be opened to the atmosphere and regulate the baseline pressure. So that is the setup of how to prime an arterial line. Thank you.